Thank you, I already lost because it's you, Johnny. Okay, let's put up my disclaimers. All the studies that I present are certainly the ones that support my argument, so I neglect all the ones that are against my arguments, and there are no high-grade studies, actually, that we can all, based on, have a good discussion. And it's always like anything, it's in the gray zones. And I have to disclose some travel and accommodation support by Fisher and Paykel. My evidence that I bring is opinion, so that's basically fake news. Then some data, like Macron, starts to build up. Obama has maybe moderate evidence brought in along, and I'm a faint believer in Angela Merkel. Unfortunately, she's on the way out, maybe high flow as well. Okay, where is high flow being used? People ask high flow versus non-invasive ventilation. I would argue there's a continuum of care, not necessarily yes or no. And you can see that standard oxygen, nasal high flow, they overlap exactly the same way like non-invasive ventilation and even invasive ventilation. But there's no hard facts. Your patient will actually tell you what type of support they will tolerate, because particularly non-invasive ventilation is a question of tolerance. So I argued the following, and I prove you the case that high flow must be started in emergency department and general wards, reduces the need to escalate therapy, reduces intubation rates, and intubation rates are lower compared to non-invasive ventilation. Therefore, we should use high flow as a first-line oxygen therapy prior to using non-invasive ventilation or intubation in parts. Definitions, very important. You have all sorts of definitions about high flow. I particularly talk about bronchiolitis here, but show you later on as well data in older children. 2 liters per kilogram per minute, blended, humidified air oxygen through nasal prong. I think that should be delivered at least under 12 months of age. Importantly, you should deliver as much as possible. You need to meet the inspiratory demand. If you don't meet the inspiratory demand, the patient will entrap air around the nasal cannula. The nasal cannula will serve as an obstruction. You have increased work of breathing, so you have to match the inspiratory demand. Otherwise, the patient inhales air, and you don't actually know how much oxygen you deliver. These are the flow rates that I mandate to be used. I make a strong argument here. I'm not going into the detail, but they max and match the minute volume of any given patient that you encounter, particularly outside intensive care. So, needs to start outside ICU. We've performed recently a trial, the Paris trial, in ED, in general wards. We measured the escalation rate, standard oxygen versus high flow. We could demonstrate that such a trial performed in 17 centers with 1,400 patients enrolled with clear escalation criteria. We could demonstrate in this trial quite nicely that high flow is superior to standard oxygen. So certainly you can avoid escalation of care. And again, I'm talking here in gray zones. If you carefully look into our trial, there may be some good weaknesses in this trial, some good arguments to argue against my conclusion. But I've been asked here to talk for pro, so I'm painting black. I know our trial is more gray than black, so please carefully read the trial. I have some question marks as well in our conclusions, but if you publish in the New England Journal, you're not allowed to draw any recommendations, so that's what it is. We have demonstrated in this trial a 23% failure rate in standard oxygen versus 12% failure rate in high flow, a clear 11% difference, so 1 in 9 children need to be treated to avoid escalation of care. So, certainly good evidence here, Merkel gets a point. High flow reduces the need to escalate therapy. Again, in our trial, in the standard oxygen arm, all of the standard oxygen patients were allowed to escalate, if they needed escalation, to high flow. And if you look with this trial design and the overall outcome in our trial, so that means just if you include a trial in high flow at all, we had a 1% intubation rate. So out of 1,400 patients enrolled in a trial with so-called moderate to severe bronchiolitis, we had only 1% intubated. No matter if you start high flow early or you rescue with high flow, this is a staggering low intubation rate. So my argument, if you, first of all, do a trial and use in the trial outside ICU, high flow, it's very likely you prevent intubation and ventilation of these patients. And as you can see here as well in the rebuttals or letters to the New England Journal, since the introduction and the Paris trials in Australia and New Zealand, 2014, our ICU admissions are going down, and the latest 2018 admission rates are coming down again. Whereas, for instance, on the left-hand side in Holland, they're still struggling with too much ICU admissions because they still don't use high flow regularly outside ICU. So again, Merkel gets a point. Reduces the intubation rate. Not entirely sure. We demonstrated that since 2005, we have a significant reduction from 1/3 of intubated bronchiolitic infants down to 3–5%. I'm not entirely sure if that's just the high flow. Could be better patient care, people using more non-invasive ventilation. We know intubation and ventilation is bad for you. However, we know that if you take any given patient with a risk factor associated, for instance, bronchopulmonary dysplasia or heart disease, and you look at different units in Australia and New Zealand, you can see on the left upper end, there are units, they still use 35% of intubated and ventilated patients, where at the lower right-hand side, there are units they're using high flow, and they intubate and ventilate these patients, same risk in around 8 to 10%. So depending on what your preference is, we do practice very, very differently, which is actually not good because we know mechanical ventilation impacts on the neurodevelopment. So previously healthy, normal infants in this database had, after mechanical ventilation with bronchiolitis, a neuroimpairment after ventilation. So sort of Macron may get some points. I think he's on the uprise, but we need better data for this. I will show that later on as well in my second talk in this session. Reduces the intubation rate compared to non-invasive ventilation. Here, the adult trial from Frat a few years ago, he could demonstrate no differences between intubation rate between standard oxygen, nasal high flow, and non-invasive ventilation. He only could show that the mortality rate after 90 days was lowest in the high flow arm. So there's some signal there that high flow does good for you, but that's a single study that we may not believe in. And you can see here is the mortality rate, which quite surprisingly showed that high flow is superior to non-invasive ventilation. I wouldn't have guessed that. This is the data that needs to be confirmed. However, if you do then a lot of meta-analysis data in the adult world, high flow is certainly superior to non-invasive ventilation in adults, preventing intubation. So we have a real good difference that high flow shows in the adult world a clear reduction in intubation rate, and I think that's as good as the data gets because we don't have similar good randomized controlled trials in children. A recent trial just being published in the PCCM showed that in an American database, when you use high flow as a first-line treatment in respiratory disease and bronchiolitis, again, in ICU, most of the units, more than 5,000 patients used high flow first-line treatment. Around 1,000 used non-invasive ventilation as a first-line treatment for bronchiolitis in ICU. When then they analyzed this data against the intubation rates that occurred and risk-adjusted it even, it was a clear difference. You had a 20% to receive an endotracheal tube if you had first-line treatment of non-invasive ventilation versus 10%. And if you did a risk adjustment for the severity, because obviously these groups were not, similarly matched, but they were then risk adjusted, they even found that non-invasive ventilation is a risk factor. Is a risk factor to score an endotracheal tube. So I have a very strong argument out of the database that we need to consider a randomized controlled trial, early use of high flow versus early use of non-invasive ventilation in respiratory patients within ICU to see if we can, similarly to the adults, reduce intubation rate. Here, certainly, I give Obama some credit that based on good data, we may have to do some more randomized controlled trials. And to conclude, and would strongly argue, for your current knowledge and for your current practice, you should use nasal high flow first, but you may have to escalate to non-invasive ventilation because I'm still a strong believer that some patients with more severe disease will benefit from non-invasive ventilation because high flow probably is not as effective in the more severe end of parts or severe acute hypoxic respiratory failure. So I'll conclude, yes, you should use high flow as a primary therapy over non-invasive ventilation. Thank you very much.